Hi, my name is Alicia Ballesteros.
And I'm Bailey Nermia.
And I'm Janelle Eliason, and this is our safety analysis project on preoperative checklists.
Checklists were first utilized in aviation around 1930 to address the issue of human error as newer and more complex aviation were introduced. They are now more commonly used in high-risk industries such as the medical field, and in 2007, the World Health Organization launched the Second Lives Global Patient Safety Challenge, Safe Surgery Saves Lives. The aim of this challenge was to improve safety of patients undergoing surgical procedures around the world. The current estimate for complications following surgery is over 7 million people worldwide. It is also estimated that 1 million of these people will die as a result. Around half of the complications that occur are potentially preventable.
In 2007, the World Health Organization, abbreviated WHO, developed a system of checklists for surgical teams that serve as a physical reminder to do their checks before, during, and after performing surgery on a patient. These checklists were updated in 2012 to better correlate with complications arising in the operating room. The most basic surgical checklists have three categories: the sign-in that said out loud before the induction of anesthesia, the timeout that said out loud and confirmed by the entire surgical team before the first incision, and the sign-out before any member of the surgical team leaves the OR. These are a lot like our rights and checks before administering medication to a patient. This is an example of a basic surgical checklist. As you can see, it covers the three phases of the WHO guidelines from the sign-in to the sign-out. The sign-in portion is used to confirm that we have the right patient, site, and procedure, and that the consent form has been signed. The timeout is the second check to confirm that they are doing the right procedure on the right patient and on the right site, and is done before the first incision. The sign-out is the final verbal confirmation and instrument count that is done before any member of the surgical team leaves the OR. Major complications after surgical procedures occur in about 3 to 17% of inpatient operations. According to the WHO website, a study done in 2008 discovered that the use of surgical checklists reduced the occurrence of sentinel events in the operating room by at least 1/3. In 2010, Stanford University presented their findings at the American College of Surgeons annual clinical congress held in Washington, D.C. Their findings concluded that with a modified version of the surgical checklist, mortality declined from 0.88 in quarter 1 to 0.80 in quarter 2. The checklist also increased the frequency in which staff members reported patient safety never events, and the incidence of patient safety never events related to errors or complications decreased from 35.3% to 24.3%. It also increased the communication between members of the surgical care team, thus improving the quality of care. The importance of the checklist in preventing error is widely agreed upon by healthcare professionals. These complications include wrong patient, procedure, or the site of the surgery, anesthesia equipment problems, lack of availability of the necessary equipment, unanticipated blood loss, non-sterile equipment, and surgical items, like sponges, left inside of patients. Though healthcare professionals agree on their importance, there's only moderate compliance. Checklists are seen as redundant and just another tick mark in a box. Though 93.1% of operations use the checklist, only 57.2% of surgical teams actually complete the checklist.
Now we're going to talk about some of the stakeholders that are involved with this issue. First, we have hospital leaders. Hospital leaders are a key part of this issue because they are responsible for mandating the policies and procedures of the checklist and determining how they will be implemented and taught. Although most hospitals have some sort of preoperative checklist, there's a lot of variance in the effectiveness, and this can be related to the policy and how it's written and how it's instated. It's really beneficial for hospital leaders to encourage these checklists because they have a huge decrease in surgical error. Having a hospital with high amounts of surgical error is expensive, so they're really interested in cutting down their budget, and this will help. In 2008, Medicare and Medicaid announced that they would no longer reimburse institutions for surgical errors if they were related to wrong site or retained surgical objects. So because of this policy, hospitals now have a huge reason to decrease surgical error and really implement those checklists well. Next, we have surgeons. Surgeons obviously play a main role in this issue as they are kind of in control when it comes to the OR. there's a lot of research from the British Medical Journal which suggests that having key stakeholders, largely surgeons, on board has a huge increase in compliance with the checklist. Because they are the obvious leader, they kind of dictate the culture that their OR will have, and whether it's one of maximum efficiency or one that's actually centered around patient care, others will follow their lead. Surgeons also benefit from adhering to the checklist because it reduces not only their record of errors, so thereby boosting their prestige, but gives them more positive patient outcomes and patient success. Next is anesthesia. They're a major part of the OR team and so also have a large stake in this issue. The checklists require that everyone in the room agrees that it is the right patient, procedure, time, that we have adequate emergency equipment and supplies, etc. So it's important that they are aware and on board with what's going on. Proper implementation of these checklists will also empower anesthesia and really help them to take more of a role in patient safety. They can be an important voice in either confirming or questioning that everything is how it's supposed to be. They also can help change the culture towards patient safety. Nurse managers, although not necessarily being directly in the OR, still play a crucial role in how the whole hospital operates, both in ensuring the attitude and knowledge of the nurses and also being a main communicator between different departments in the hospital. They can have a really large influence on how well these checklists are working. Having them work well with the checklist is really beneficial for the nurse managers because they already have really hectic days. So a decrease in complication will already make their day go a lot smoother. And again, happier patient outcomes is good for anyone focused on patient safety. Next, we come to nurses. Nurses are a vital part in working to eliminate this problem, as we are important parts of the OR team and also important advocates for our patient and responsible for ensuring their safety. Nurses, like the rest of the OR team, are key in speaking up during the various checklists. They provide an important voice that makes sure everyone is on the same page. I want to draw special attention to them, though, both because this is the role that is most applicable to us, but also because this is the role the system makes the hardest to do. In recent research, qualitative data has shown that nurse confidence, the confidence to challenge the surgeon or the rest of the team, has been a factor in the checklist not providing the defense that they should. Many OR nurses describe the hierarchical nature of the OR as being a huge barrier in their job to ensure patient safety. So a large responsibility goes to us to go against the hierarchy and still advocate for our patients. This will benefit us because it will again give us that more power. It'll help ensure patient safety and more successful outcomes, which is every nurse's goal. Last, we come to the patients. Patients are some of the least talked about stakeholders in this, but although the issue is centered completely around their care. Patients provide the information that is being checked, from allergies to name to proper site and diagnosis, and can be used to confirm or deny that the physician has the correct information. Decreasing surgical errors would benefit the patients most, as they would have to endure less complications involved with surgery. All in all, the important thing to note with all these stakeholders is the importance of the team dynamic that they must possess. In recent research by Conley, they looked at the different ways that hospitals implemented the checklist and found decisively that the most effective installation came from implementing the policies to the complete OR team through various educational sessions, open feedback opportunities, and a complete dialogue between all groups involved. This helped to foster an environment where the whole surgical team understood the rationale and recognized their important role in ensuring their patient safety. With all these different groups at play, it's easy to see how a complex adaptive system forms. Operating rooms are completely nonlinear. There's no way to predict the outcomes. Same procedures with same type of person can have infinite number of results. There's no way to know the true input which will equal the output. It's also an open system with dynamic moving boundaries, tons of different teams working one with each other through anesthesia team, through the surgical team, nursing team, and then also working within the hospital. With these complex adaptive systems, it means that there's a lot of room for adverse events to occur, or human error. And the only way to really decrease these are to identify and fix the organizational conditions, not just by implementing these checks, but shifting the culture to understand why we need the checks. A way that hospitals have worked to make this culture shift is by explaining to their staff the Swiss cheese model for error. This model understands that healthcare are complex adaptive systems and acknowledges that it is filled with humans, so given the dynamic nature of the system, is very susceptible to human error. There's also been a lot of research that shows that reprimanding individuals does nothing to actually improve the patient safety or prevent errors, so hospitals have begun to look at the bigger system. In this, the Swiss cheese model was created. We can think of the holes as errors and the slices of cheese as the different defensive layers, or the checks. Although each defensive layer is not completely infallible to human error, if we layer enough on top of each other, then we can still make the cheese impermeable. This is an effective way to think about preoperative checklists, and although they may seem redundant as layer and layer after cheese, it'll actually help to realize that they'll prevent inevitable human error that can occur.
Here are some recommendations for action. Checklists should be evidence-based with support from various trial studies, and they should address key safety items that are often overlooked. It is important that the healthcare professional involved with the checklist conducts active and accurate checks. When implementing a preoperative checklist, ensure the correct use of the checklist is properly explained and demonstrated. Patient safety is a multimodal action. Workshops and other ways to enhance safety education alongside use of the checklist will foster the best outcomes. Senior hospital leaders should also lead by example and commit to implementing the use of the checklist. Checklists should not be memorized as they are in place to prevent things that are often overlooked. Since every medical facility is different, nurses, physicians, and other healthcare professionals need to fully engage in bringing about local modifications to the checklist and implementation process. It must be recognized that successful implementation of a checklist may take time, and this also includes continually looking for ways to improve and figuring out what works best and what does not. Here are some reasons why we would want to use a preoperative checklist. Preoperative checklists aid in the prevention of errors related to surgeries and minimize the risk for complications. It also decreases unnecessary hospital expenses related to surgical errors. Checklists promote consistency and helps to ensure that safety steps are reliably followed for each operation. Checklists contribute to communication of all healthcare team and helps increase situational awareness among team members. In 2007 and 2008, the World Health Organization conducted a study exploring the effects of the preoperative checklist. 8 hospitals located in Canada, India, Jordan, New Zealand, Philippines, Tanzania, England, and Washington participated in this study. The sample size as a whole was selected to represent a variety of economic circumstances and diverse populations of patients. Researchers collected data on clinical processes and surgical outcomes from 3,733 patients who were 16 years of age or older undergoing non-cardiac surgery after the introduction of the surgical safety checklist. The implementation and utilization of the WHO surgical checklist reduced the rate of deaths and surgical complications by more than 1/3 across all 8 hospitals. The rate of major inpatient complications dropped from 11% to 7%, and the inpatient death rate following major operations also decreased from 1.5% to 0.8%. In conclusion, these findings of the study support the use of the preoperative checklists can reduce the occurrence of sentinel events related to surgery. Here are some disadvantages to using a checklist. Checklists may be viewed as a compliance tool rather than a team tool. Some healthcare professionals may feel that checklists undermine professional judgment, and medical personnel may also feel that the checklists are unmanageably complex and contain too many checks that are not pertinent to the surgical procedure. We can evaluate our new safety recommendations in a few ways. Keep track of surgeries with negative outcomes, monitor amount of surgical errors, specifically wrong site surgical errors or preventable ones, and have check-ins with stakeholders and assess feelings towards checklists and compliance. So this concludes our safety analysis project.
Thanks for watching. Hope you guys learned a lot.